Genital ulcers are not all the same. Understanding the distinct characteristics of different genital ulcer presentations is crucial for accurate diagnosis and appropriate treatment. Each condition has unique features that help differentiate one from another. Genital ulcers represent a diverse group of conditions with varying etiologies, presentations, and clinical implications. Proper identification requires careful attention to morphology, associated symptoms, and patient history. This involves understanding infectious causes, conducting clinical assessments, and making differential diagnoses. A systematic approach to genital ulcer evaluation involves careful examination of key clinical features that help distinguish between different etiologies. This includes visual inspection, pain assessment, lymph node examination, and laboratory testing to obtain appropriate specimens for definitive diagnosis. Herpes simplex virus, either type 1 or 2, causes characteristic clusters of painful vesicles that quickly rupture to form shallow, tender ulcerations. The initial outbreak is typically more severe than recurrent episodes. HSV is the most common cause of genital ulceration worldwide, with HSV-2 being more frequently associated with genital disease. Chancroid presents as deep, painful ulcers with irregular borders and a purulent base. The associated lymphadenopathy can progress to suppuration, forming characteristic buboes. Chancroid is more common in tropical and subtropical regions and is associated with increased HIV transmission risk. Pain is one of the most important distinguishing features when evaluating genital ulcers. This characteristic helps narrow the differential diagnosis significantly. Painful ulcers include those caused by herpes simplex virus, chancroid, and others, while painless ulcers are often due to conditions like primary syphilis and LGV. Syphilis typically presents as the classic chancre, a solitary, painless, indurated ulcer with clean borders and base. The associated lymphadenopathy is characteristically non-tender, helping distinguish it from other conditions. The painless nature of primary syphilis can lead to delayed diagnosis, so always consider syphilis in painless genital ulcers. LGV typically presents with a small, transient primary lesion that may go unnoticed, followed by prominent tender lymphadenopathy. The lymph nodes may rupture and drain. LGV is caused by specific serovars of Chlamydia trachomatis that are more invasive than typical genital chlamydial strains. Donovanosis, also known as granuloma inguinale, is characterized by chronic, progressive ulceration with a distinctive beefy red, granulomatous appearance. The lesions can spread through auto-inoculation, evolving from a small, painless papule to a beefy red friable ulcer, and may develop satellite lesions. Key differences in genital ulcers include pain, number of ulcers, lymph nodes, and purulence. Understanding these features helps in differentiating between conditions like HSV, chancroid, syphilis, and others. Each condition presents with unique characteristics that aid in accurate diagnosis. Accurate diagnosis of genital ulcers requires integration of clinical findings with appropriate laboratory testing. Each condition has characteristic features, but overlap can occur, making laboratory confirmation essential for optimal patient care. Early diagnosis and treatment not only improve patient outcomes but also reduce the risk of HIV transmission and other complications.